This video is about the physical assessment of the pediatric patient, Chapter 5. Okay, the first thing you want to consider when you are assessing a pediatric patient is what they're coming in for. What are they complaining of? So the current illness, and then how long has it been going on? Is it an acute condition or chronic? If there is any type of infection in addition to the symptoms they are experiencing, that is very important. The patient has been treated for this problem before. You need to find that out. And then what did they do when the patient came in with that problem? What type of therapy was given so that we can possibly continue on with that same regime? Are there any other family members that have similar symptoms? If they have a cough, what's the character of the cough? And the pattern of breathing is also important. If the patient is wheezing, as you know, we need to treat that with specific medication. Is the patient cyanotic? Because that can show signs of either oxygenation issues or perfusion problems. Does the patient complain of any chest pain along with these symptoms? Because again, that can show that maybe there's been some trauma or some type of cardiac abnormality. The nature of the sputum, color, consistency, the odor, and then growth pattern. If the patient has some type of condition that is stunting their growth, then that is very important for us to know. And last but not least, the environment that the patient lives in is extremely important because the environment can exacerbate certain pulmonary conditions. Okay, in addition to assessing the patient, you also want to know what their lab results are. You see here a list of the normal lab values for pediatric patients. The one that is very important and is something new to you is sweat chloride test. The sweat chloride test is used to determine if a patient is positive for cystic fibrosis. The normal values are less than 40 milliequivalents per liter. If a patient has greater than 60 milliequivalents per liter on a sweat chloride test, they must be tested twice. And if the values are greater than 60 on two separate attempts, then the patient is diagnosed with cystic fibrosis. Okay, now that you've collected a history and looked at the labs, you want to examine your patient. And I know the textbook says that there are 3 primary goals, but assessing the airway is also a primary goal. So we're going to have 4 primary goals that we will discuss. Okay, when you're assessing the airway of a pediatric patient, you always want to check for patency. If it is not patent, if the airway is not patent, you want to position the patient and open the airway manually. Head tilt, chin lift, just like in CPR. If there is an object present that you can actually see, then you can go ahead and remove it. If the patient is unresponsive, then of course you want to do CPR. If the airway is not patent and manual manipulation of the airway causes it to open, you may have to insert an oral airway or nasal or even an endotracheal tube. Suction the oral pharynx if there is secretions present, because that alone could cause the airway not to remain open. And then suction the trachea if the patient has a tracheostomy instead of their normal airway. Determining the nature of respirations includes looking at not just how fast they're breathing, but also how deep, the actual rhythm, how regular it is, or how irregular it is, And then the ease of breathing. What kind of effort are they taking to breathe? The rate is a good indicator that the patient is in some type of distress. So know your normal ranges for the respiratory rate. And if the patient is, of course, tachypnic, then you know that they are in distress. But also, bradypnea shows that a patient is in distress as well, because if you are tachypnic for too long of a period, then of course your respiratory rate can go from being very fast to very slow. The depth extremes are easily detected on pediatric patients because of their chest diameter. Look for abdominal movement because they will, of course, incorporate their accessory muscles of inspiration. And so you will see the abdomen being utilized for them to breathe. Hyperpnea is just a term that you need to know that deals with how deep a person is breathing. So overly deep is hyperpnea. Hypopnea is when someone is breathing shallowly. We'll also look at the rhythm. Normal rhythms will include an occasional sigh. It's more prevalent in the neonate and pediatric population, but also seen in adults. Abnormal rhythms may include periods of apnea, which is very common in the pediatric community, especially neonates. You will be looking at them, and one moment you see chest rise, and the next moment you don't. Even though it's commonplace, it is still considered an abnormal rhythm to have periods of apnea. And then the effort. Do they have labored breathing, which is often shown by having some type of retraction where they are pulling in not just their accessory muscles, but also the skin above it, the dermis. You can see it being incorporated in trying to overcome the either obstruction or resistance. Retractions will be seen either intercostally, meaning in between the ribs, substernally, which is seen by the lower part of the chest wall right below the xiphoid process being pulled in to help get the volume out. So that is used on expiration. And in subclavicular, right there where the clavicles are, you'll see the skin being pulled in that area as well. Okay, we talked about hypopnea and hyperpnea, but there are some other common respiratory abnormality terms you need to know. Orthopnea should be familiar to you already, and that is the the need to sit upright in order to breathe. Dyspnea, you already know what that is. General malaise is a term that is used when the person just doesn't feel right. They just don't feel good. Can't really describe it. That's usually called general malaise. And that is an indicator of electrolyte imbalance. The NBRC loves to use that term when the patient maybe has like a low potassium level, or potassium is usually the main one that they utilize on the exam. Tachypnea, causes can be due to fear, hypoxia, pain, anxiety, metabolic acidosis. So just the fact that a patient is tachypnic doesn't really tell you much. You have to do some more assessing to determine why they are tachypnic. Bradypnea, also you want to find out what the cause is. Could be drug related that's causing them to to slow down their breathing. They could have alcohol on board. They could have some type of metabolic disorder, or they could be asleep. Because as you know, when you fall asleep, your breathing slows down. Cheyne-Stokes is a term that you learned last semester as well, and it is always indicative of a patient that has had some type of trauma to the head, therefore thereby having increased intracranial pressures. Patient could have meningitis, which is inflammation of the meninges, and if your meninges are inflamed, then you're going to have increased pressure in the cranium. And also drug overdose. Certain drugs can cause the patient's breathing pattern to be off and present like Cheyne-Stokes. And the last abnormal term is Kussmaul's breathing. Learned this last term as well, but the common causes of Kussmaul breathing are metabolic acidosis, renal failure, and diabetic ketoacidosis. Now, while you are determining the nature of the respirations, go ahead and inspect the chest. Look for accessory muscle activity and retractions. Look for any anatomical chest abnormalities. If it's a trauma patient, look to see if there's any impaled objects. Sometimes the anatomy, because the children are growing, could be abnormal simply because of their growth rate. Look to see if things are asymmetrical. The chest cavity may be abnormal simply because it is asymmetrical. Things that can cause the chest wall to move asymmetrically, which is different than the actual anatomy being not symmetrical. If the chest wall moves asymmetrically when they inhale and exhale, it can be due to a pneumothorax, atelectasis, improperly placed ET tube, pneumonia. Of course, if the phrenic nerve is paralyzed, phrenic nerve palsy, or if one of the diaphragms is paralyzed, hemidiaphragmatic paralysis. Any of those could cause the chest wall movement to be asymmetrical, meaning one side would be moving up and the other side will be moving down when the patient goes to take in a breath. Now, in order to observe adequate gas exchange, the best way to do that, of course, is to obtain and analyze an ABG. However, in the neonatal and pediatric community, we utilize a lot of pulse oximetry and transcutaneous monitoring to decrease the amount of times that we are sticking the patient, because it's not as easy getting ABGs from a child or a pediatric patient because they don't actually cooperate as well as adults. And some adults don't cooperate well either. But we utilize pulse oximetry and transcutaneous monitoring as a way to assess the adequacy of gas exchange. And if we ever are questioning the values that we're getting via pulse oximetry and transcutaneous monitoring, we always confirm that with an ABG. But there are physical signs that we can look at in addition to pulse oximetry and transcutaneous monitoring. And as you should know, one of the telltale signs of poor gas exchange is hypoxemia. So look for the physical signs of hypoxemia, which include tachycardia, cyanosis, labored breathing, and deteriorating mental status. Those are all signs that your oxygen level in your blood is low. Physical signs that may indicate hypercarbia also can tell you that adequate gas exchange is not happening. If your pulse is rapid and bounding, MBRC loves to use rapid bounding pulse to hopefully get you to think about the CO2. Confusion or drowsiness can also be an indicator that the patient has increased CO2 levels. Muscular twitching is another indicator, as well as coma. So if the patient has hypercarbia, you should also be thinking that my patient is not ventilating, right? Because an increased level in CO2 indicates ventilatory failure and respiratory acidosis, if you want to go way back to the first month of the program. All of those signs tell you that there is poor gas exchange between the venous system and the alveoli. So as the tissues are giving off CO2, they are sending or transporting that CO2 back to the lungs, and for whatever reason, the CO2 is not able to escape out of the body, usually because the patient is not ventilating properly. So all those are physical signs that you need to look for that can tell you that the patient may be, and these are may signs, like they could possibly be telling you that, but it doesn't always mean that that is it. But when you hear these terms, especially on the MBRC exam, you should be thinking about the particular condition that goes with that term. Diminished breath sounds with any of the symptom listed above, whether that's hypoxemia or hypercarbia, always, always, always make sure that you put the patient on oxygen and get an ABG. Okay, finding the exact location of the disease or disproving that there is a disease even present includes things such as auscultating the chest cavity, percussing the chest, palpating the chest, as well as any additional upper airway structures, and also obtaining a chest x-ray. So when you are doing your assessment, make sure that you have gotten a really good history, because the history is going to help you then focus your chest assessment when you're going to auscultate, percuss, and palpate. Even more so when you do the chest x-ray. So when you're viewing the chest x-ray, because of the history, you already know where you need to focus your viewing of the chest x-ray. You want to look on the left side or the right side, or is it diffuse? Is it throughout the chest cavity? Speaking of chest x-rays, the only purpose that you're getting a chest x-ray is to confirm what you already believe is going on. You cannot use a chest x-ray in and of itself to diagnose anything. We talked about that last semester. Auscultation, you want to listen to the chest wall, listening to the breath sounds. Make sure you know the breath sounds and what they indicate. So when you hear wheezing, what does that indicate? Rhonchi and so forth. Know what those things mean, because you will see them on the MBRC exam. Percussion, make sure you know the difference between hyperresonant and dull notes when you are talking about percussion. They also may use the word tympanic. For palpating, usually when they're talking about palpation, they're going to throw in some deviated tracheas and things of that nature. You can also palpate subcutaneous emphysema, but palpating is nothing but touching the chest wall or the upper airway. So you can look to see if things are midline or if they are deviated. And if something is deviated, you always want to make sure that you find out if it is deviated towards the affected side or away from the affected side. Okay, now we're going to talk about the vital signs that you need to be aware of for pediatric patients. The ranges are listed here for the different age ranges. So from 1 to 2, it's 80 to 130. We expect a faster heart rate the younger they are. Then it starts to taper off a little bit, 70 to 120 for 2 to 6, 70 to 110 for 6 to 10 years old, and then greater than 8, they just lump that all into one big category, and that's 60 to 100 beats per minute. For respiratory rate, we will accept all the way up to 30 beats a minute as normal for a toddler, and toddler is 1 to 3 years of age. Preschool is considered 3 to 6 years of age, and we're getting closer to that normal range that you are already used to for adults, but the preschooler is 16 to 22. And then school aged, which would be first grade on up, would be 6 years to 10 years old, and that's 16 to 20. And then adolescence incorporates those tween years all the way up to 17 years old, so 10 to 17, and their respirations are the same range as it would be for an adult. As you know, for blood pressure, we always look at the systolic pressure to indicate whether there is some type of increase or decrease in the pressure, simply because when we get into invasive monitoring of blood pressure, the systolic pressure is the focal point. But 1 to 2 years, the systolic range is anywhere from 85 to 105. For a 2 to 6 year old, 95 to 105. And for a 6 to 10 year old, it would be 95 to 110. And then greater than 10 years of age, 115 to 128 millimeters of mercury is normal for blood pressure. Well, this concludes our lecture for Chapter 5 on pediatric assessment.